pancreatitis. My talk today will cover acute pancreatitis, acute recurrent pancreatitis, chronic pancreatitis, and what's the diagnosis and the management of every one of those three conditions. If we say pancreatitis, it's kind of affecting the pancreas. So we ask ourselves, what's the function of pancreas? As we know, simply we have endocrine and exocrine function. The endocrine function of pancreas, as you know, it's release certain hormone like insulin, glucagon, somatostatin, and the exocrine function, as we mentioned in the malabsorption, it's secreting certain enzyme like trypsinogen and chymotrypsinogen. Also, it secretes certain hormone to control GI tract like gastrin, secretin, and CCK. So this is the function of pancreas. If we have inflammation, either acute or mainly chronic, it can interfere with those one. But again, pancreas it contains certain pro-enzymes, so inflammations can lead to autodigestion. So if you have an inflammation of pancreas with whatever initial insult, it will injure the acinar cells, which lead to release of pro-enzymes, and this premature activation of this enzyme it's leading to autodigestion. So pancreas is very sensitive organ. For any insult of pancreas, either trauma, the surgeon they know the pancreas well. During any surgery, they try to avoid and not even to touch the pancreas because it's very sensitive organ and it can lead to initiation of pancreatitis. So trauma, surgical is one causes of pancreatitis, and other differential and causes of acute pancreatitis, we will cover it. But inflammation of pancreas, it can manifest with pain, increased transaminases, with ultrasound finding, which we will cover. And they can go into acute pancreatitis. 80% of acute pancreatitis, it is mild. We call it edematous or interstitial. So it's self-resolved. However, in 20%, it can goes into necrotizing form, by which those patients it can goes with higher morbidity and mortality because of abscess formations, necrosis, pseudocysts, and those need some antibiotics, and some of them require intensive care monitor. But most of them, luckily, they have milder form, as we mentioned, in 80%. Recent study shows an increased incidence of acute pancreatitis, and almost now in pediatric population, we are approaching the adult reported cases of incidence. Is this true, or because we are now having more awareness about this condition and we look for it? It's my expectation is both condition, it can lead to this increased incidence of pancreatitis. Acute pancreatitis in children, it can be secondary to biliary disorder like choledochal cyst or cholelithiasis or biliary sludge, or secondary to anatomical anomalies within the biliary tree like pancreatic dwarfism or annular pancreas or diverticulums or Crohn's disease. Medication like faloperidol, amuran, asparaginase can lead to pancreatitis. For sure, trauma is one of the commonest, especially, blunt trauma to the abdomen. It can be idiopathic. Idiopathic form of pancreatitis become less and less as we are finding more disease leading to pancreatitis, like hereditary pancreatitis. And now we have certain gene like BRIS1 and SPINK1 gene, which can lead to hereditary pancreatitis. Infection, metabolic disorder, organic acidemia, isovaleric acidemias can lead to pancreatitis. And there is a new entity called autoimmune pancreatitis, which is now, it's more or less common in adult, but autoimmune pancreatitis is a treatable condition, and always we should look for it, especially if it's recurrent. How they can present? As you know, most of those patients, the commonest presentation, they will come with abdominal pain. However, in pediatrics, it can be non-specific. If it's infant, it can have only irritability because the baby and infant, he can't say I have abdominal pain. So they will have irritability, nausea, vomiting, and it can have jaundice if it's biliary process. Sign of abdominal pains can be by tenderness, and in advanced cases, they can have the gray Turner signs and the Cullen sign, which indicate there is a retroperitoneal hemorrhage. So Cullen signs is this discoloration around your umbilicus, and the gray Turner sign is this discoloration in the flank. Sometimes they can have, if it's severe pleural effusion, respiratory distress, and some of them, they can even have fever, shock if it's advanced cases. How we can make the diagnosis? If we have 2 out of those 3, it is sufficient: abdominal pain or serum amylase and lipase 3 times of normal, or imaging finding compatible with acute pancreatitis. As we said, mild form is 80 to 90%, and normally it is limited to the pancreas. However, if it's severe form leading to abscess and pancreatic necrosis, it can lead to DIC picture and collapse of the patient. So those severe forms need cardiac monitor, ICU, hydration. If you have increased amylases and lipases, it's not always indicate it's pancreatitis. This is certain differential diagnosis of increased amylases other than acute pancreatitis, biliary tract disease, mesenteric infarction, appendicitis, ovarian neoplasia. It can lead to amylase elevation. Lipase elevation is more specific to pancreatitis. However, again, acute cholecystitis, esophagitis, peptic ulcer disease can lead to increased lipase. So always, once you have amylases and lipases, it's not 100% pancreatitis. You should look for other modalities in order to have the criteria to diagnose pancreatitis, which is either abdominal pain or imaging finding compatible with pancreatitis, like ultrasound. You will have bulky pancreas or pseudocyst. So we can classify pancreatitis according to the presentation. The mild form, it's limited to the pancreas. They will not have organ failure. The moderate severe form, they can have transient organ failure. However, the severe form, they will have certain persistence of organ failure beyond 48 hours. Management: pancreatic rest, fluid supplement. It's very crucial. The old school of putting those patients in BO as a bowel and pancreatic rest for long term is not applicable anymore. Normally, we limit it to 24 hours, and we start regular diet as early as possible. There is no evidence low-fat diet or avoiding diet for long period is recommended in those patients, unless the patient had complication like ileus, pancreatic fistulas, or compartment syndrome. Those patients, which is certain condition of pancreatitis, they will need some TBN management. However, we need to initiate enteral nutrition as early as possible, because study showed if you put those patients in BO, it can lead for long period bacteria translocation. So bacteria translocations can increase the incidence of sepsis and the PICU admission, whereas enteral and initiating enteral nutrition, it's prevent this bacteria translocation, and this will help the prognosis with lower incidence of infection, with lower incidence of multi-organ failure, and lower incidence of surgical rate and mortality. So now the evidence support early introduction of enteral nutrition. The other management option, as you know, those patients, they will have pain, so they may require analgesia like morphine. Antibiotics is not typical to be given unless you are dealing with a severe form of pancreatitis, and there is an evidence of necrosis and abscesses. And always monitor the complication, because the complications can be just local, like localized to the pancreas with edemas and abscess, pseudocyst, or it can be systemic. They can go into shock. It can lead to hypovolemic shock. They can have hyper metabolic state leading to some electrolyte disturbance, sepsis. So always look for those systemic complications. If the patient is going to die from pancreatitis because of this multi-organ systemic failure and DIC. So those severe forms really need monitoring in the ICU with IV antibiotics. And thanks God, this is a very limited, as we said, less than 10%. Clear? Any question regarding acute pancreatitis? Hello?
Thank you.
Okay. Acute recurrent pancreatitis is more or less as acute pancreatitis, however, it's recurrent. So if you have 2 or more episodes of acute pancreatitis per year, or 3 episodes or more than 3 episodes over your lifetime, we call this one acute recurrent pancreatitis. Why we are coming with this definition? Because we think those patients, they have other differential and they need more escalating in your workup to look why those patients have this recurrent pancreatitis. And 10 to 20% the patient who had acute pancreatitis tend to have this recurrence. And the most important, those patients look for a disease process leading to the recurrence. The most important things is really to look for anatomical anomalies. Normally, we didn't recommend MRCP or ARCP for patients who are present with acute pancreatitis in the initial phase, unless you have certain finding in your ultrasound to suggest there is something and the problem with the biliary tree, or the patient had recurrent attack of pancreatitis and you didn't know what to do, and your initial workup for metabolic disorder or infection is excluded and there is no history of trauma. So in those patients, you will look further for a cause, as we said, anatomical anomalies, colorectal cyst, pancreatic divism, or even you can start to do certain gene testing, because hereditary pancreatitis can present. Always look for autoimmune pancreatitis or chronic inflammatory process like Crohn's disease. Again, medication, if it's there, you should look for alternative, especially if the patient had recurrent pancreatitis. And normally with the initial pancreatitis, we should really exclude those medication and look for other alternative. Pancreatic divism in pediatric, they can present with recurrent acute pancreatitis, and this is anatomical anomalies during the development of pancreas, by which the dorsal aspect or the dorsal duct of the pancreas, they will, instead of having common opening and normally they join together, the dorsal aspect, they have their single duct in the minor papillae, whereas the ventral aspect, it goes into the other. So as you are having dual separate drainage of the pancreatic secretion, and we know that the minor umbilical is not great big sphincter, so those patients, they will have recurrent pancreatitis because they have this anatomical anomalies within their bile duct. Hereditary pancreatitis, BRIS1, SPINK2, CFTR, and CTRC is a cause, and especially the BRIS1 is well known to lead to pancreatitis. Normally the BRIS1, it is autosomal dominant, and rather than just leading to chronic pancreatitis, those patients, they have higher risk of pancreatic cancer, so they need good monitor for their condition, and some of them, because of recurrent pancreatitis, they can go into chronic pancreatitis. SPINK2 is the other one, however, it's milder than BRIS2. cystic fibrosis membranous conductor regulator. It can lead to, if they are pancreatic sufficient cystic fibrosis, they will develop pancreatitis, and later on they can go into pancreatic insufficient because of recurrent inflammation. Chymotrypsin C genes is a fourth type of genetic disorder which can lead to recurrent pancreatitis. How we can manage? Again, it's more or less, if they are having the acute, it's more or less treat them like acute pancreatitis. However, because they have recurrence and you are trying to find a disease, you will screen them for, as we said, genetics. You will do MRCB, you may do ERCB, because in pancreatic divism, they will need some sphincterotomies and stenting in order for the minor papillae deal with the pancreatic secretion. So now in the management of the recurrent pancreatitis, we may have some surgical intervention, especially ERCB. Autoimmune pancreatitis can be treated with steroid. So recurrent pancreatitis, look for other differential of recurrence and try to treat those cause in order to prevent the recurrent relapsing acute pancreatitis. Chronic pancreatitis, it's more or less if you start to have recurrent acute episode of pancreatitis, this can lead to irreversible destruction of pancreatic parenchyma, leading to loss of exocrine function. The commonest example, any cause of acute recurrent pancreatitis can lead to chronic pancreatitis. So because of this recurrent inflammation, it can lead to destruction, fibrosis, and pancreatic insufficiency. So this is how the cascade of event: progressive inflammatory change, chronic irreversible inflammation, fibrosis, and calcification lead to pancreatic loss function. As we said, most causes of acute recurrent pancreatitis, it can lead to chronic pancreatitis. How we can diagnose it? Based on symptom, imaging, function, and normally the diagnosis is late because you are waiting until the destruction is happen and the manifestation of the disease happen. But most of them, you will know in advance they are going into a chronic pancreatitis. The amylase lipase will be not elevated because of chronicities and the destruction of the pancreatic tissue itself, and the hallmark of those patients is pain. They have chronic intense pain, and the management of this pain sometimes needs not only analgesic, some intervention, and this secondary to the obstruction, inflammation, and neuronal inflammation and perineuronal inflammation, leading to this intensifying abdominal pain. In this stage, they can have malabsorption because they will have pancreatic insufficiency. They will have weight loss, fatty stool, diarrheas, and sometimes if they have some biliary obstructions, they can have some jaundice. If they have portal vein thrombosis, they can have upper GI hemorrhage, and they can have also diabetes because of endocrine deficiency. Management for the pain, they can use narcotic, nerve ablation therapy, or surgery because they can have pancreatic insufficiency, pancreatic enzyme replacement, endoscopic treatment for ERCB if there is ductal stricture or pancreatic stone, surgical intervention for partial resection or total pancreatectomies. They can go into transplant. If they have diabetes, you should supplement them with insulin. Again, those chronic pancreatitis, especially if it's secondary to the hereditary form, those patients need to be screened for pancreatic cancer in the future because they have high incidence of pancreatic cancer. In summary, pancreatitis prevalence is increasing in pediatric. Differential diagnosis ranging from simple trauma to infection to medication to genetic to anatomical anomalies. Diagnostic tool which we have is symptom-based, supplement with lab lipase elevation with imaging. Sorry. Okay, just 1 second. Sorry. With imaging modalities, feeding, as we said, initiated as early as possible. Non-low fat, there is no evidence low fat diet is recommended in those patients. Chronic pancreatitis, it's manifest later stage, and once you reach irreversible pancreatic and fibrosis within the pancreas. Outcome in general better than in adult. As you know, in adult they have the Apache and the Ranson scoring system, which is not applicable, so I didn't cover it. I didn't mention it because we didn't apply that Apache and Ranson system in scoring in pediatric population. Thank you very much. Any question, guys, regarding pancreatitis, acute, relapsing, chronic?
No, Dr. يعطيك العافية.
Good luck. I think it's 2 weeks for your exam.
بإذن الله دكتور.
الله يوفقكم. Have a good day. Bye bye.
Thank you, Dr. You too.